welcome today to today's episode of Visionary Voices, Optimum Healthcare IT's conversational thought leadership podcast that hosts digital and technology healthcare leaders to discuss IT innovation and transformation. I'm your host, Larry Kaiser, Chief Marketing Officer at Optimum Healthcare IT. In this episode, I'm speaking with the visionary physician executive, Dr. Chris Longhurst. Chris is the Chief Clinical and Innovation Officer at UC San Diego Health, as well as the Executive Director of the Joan and Irwin Jacobs Center for Health Innovation. Today's conversation will be very interesting and very informative as we focus on technology, the value of IT, and a very interesting clinical study that I cannot wait to dive into. Welcome to Visionary Voices, Chris.
Thanks so much for having me, Larry.
Appreciate you joining us. So we're going to jump right in and get things started today with a little segment we like to call Bandwidth Banter, which is our fun take on icebreakers for IT professionals, where we'd like to have a little fun. So I'm curious to know, since it is just about lunchtime here on the East Coast, what is your go-to burrito order, Chris?
Larry, thanks for the softball. I mean, I live here in California, so there's no doubt my favorite burrito is a California burrito. And the integration of kind of the guacamole and the fries in the burrito, it's really a perfect burrito, but I'll tell you, you can't get a perfect California burrito outside of California.
I would have to agree with you on that one. I have dabbled in the California burrito here in Florida when I used to live in New York, and it just doesn't compare. I've had an exceptional California burrito in San Diego last year at the Chime Fall Forum, so I definitely can agree with you on that one. All right, so let's call this one a second softball. What sports team has your loyalty?
Well, there's another softball. I grew up here in San Diego, and so I used to be a Chargers fan. But I gotta tell you, when the Chargers left town, that I sort of had it with that. I'm not an LA Chargers fan, but I married Kansas City, and so that pretty much makes me a Chiefs fan. And we've been watching Chiefs since long before Patrick joined the team. But it's been an incredible 7 or 8 years, and we didn't make the three-peat this last year, but we're looking to set more records.
Well, it's good to hear that you were a fan before Mahomes, which means that you're not a bandwagon fan. As a Patriots fan, nothing made me happier than to see the Chiefs not three-peat simply because Tom Brady and the Patriots never did that. So I was uh, I was very excited when they didn't three-peat because then I would never hear the end of it as a Patriots fan.
Well, my wife grew up going to Arrowhead Stadium when the Chiefs were at their worst, so definitely not a bandwagon fan. Although I have to tell you that my daughter was not that interested until Taylor Swift came in the picture.
You know, she did a lot for football last year and brought a lot of Swifties to there. So I'm curious to see if this season the sale of the women's NFL tailored apparel, increases a little bit. And honestly, I'm not a Swiftie myself, but I'd be curious to know if she was selling any kind of Travis Kelce Chiefs gear at her tour stops up until it ended. So fun
Well, I
times
gotta
at
tell you,
least.
Larry, outside of football, the sport we watch the most at home is basketball. My daughter is a terrific player in high school, and we're following the WNBA pretty closely. We got to see Caitlin Clark's last couple of games in college in person, and that's done a lot for the sport of women's basketball as well. So we've got the WNBA package, and we're rooting for the Fever.
I have growing up, I was a huge basketball fan, and then kind of in my era, I'm sure similar to yours, was the Jordans, the Birds, the Pippins, and so forth. And I
Mhm.
lost interest for so long for a pretty simple reason. Nobody could hit a mid-range jumper anymore. It was either
Yeah.
one-on-one dunks or three-point shooting. And I started watching WNBA right when it kind of first started because you know, women have a better mid-range jumper. And Caitlin Clark's a fantastic player. I love watching her play. And my daughter, who's 5.5, is just now starting to get into sports. So I try to have her watch different things. So we watched the WNBA games last season, and she was really getting into it. So we'll see if she becomes a basketball player as well. So
Yeah, I agree.
uh,
The women's league is really pure basketball. It's great to watch.
yeah. I agree. I agree. Well, thank you for participating in our bandwidth banter. Always great to have those conversations. Kind of loosens the mood a little bit. But let's jump into kind of what we're talking about today, which is IT and technology. And historically, healthcare has been known to be extremely slow when it comes to adopting new technology. And you've been in the space for 20 plus years. Do you think that's a fair statement?
I think it's a fair statement. I think what's important is what's underneath of it. There's a lot of criticism in healthcare for being so slow to adopt technology, but the reality is that we're dealing with really high risk kind of situations. And adopting technology that is not yet proven when it could, in fact, lead to hurting patients is the opposite of what anybody would want. So I would say that there's a slower adoption curve, but with good reason, which is, not only is this an industry that's highly regulated, it's also an industry that literally deals with life and death. And so there are spaces where you can point to very rapid adoption of things like, new CT or MRI scanners or new technology in the operating rooms that have been demonstrated to have great outcomes. But when it comes to software for managing, your healthcare, the adoption's been much slower than people want, but that's partly just because of the complexity of the processes and the importance of getting it right. We don't have the luxury of breaking things fast and early.
So I would say, and maybe, you look at kind of COVID, and I think COVID changed a lot of things with regards to healthcare. And to me, it was buzzwords like telemedicine, remote care. All of a sudden, everybody was shoving these systems in because of COVID. And I think what I've noticed from a trend after is that everybody was going back and fixing those installs or fixing that. Do you think COVID changed how quickly healthcare will adopt things in the future, technology wise, or was that a result of a necessity of a pandemic?
Yeah, Larry, I think that the pandemic was an aberration in terms of telehealth adoption. But you have to realize that it wasn't the technology that was the barrier ever, right? It was the incentives and the policies. And
Yeah.
so when those were removed and there was an incentive to actually adopt telehealth, it went way up quickly. I mean, I remember moving tens of thousands of appointments to telehealth, those first couple of weeks. And the good news was that we were in an environment with our electronic health record vendor where we were hosted. We had already been doing a fair amount of telehealth previously, and we were able to scale that up without any technology challenges. In fact, we didn't change our technology solutions once during the pandemic. It just scaled for us. And that was really a reflection of great work that had been done for 3 to 5 years previously around getting our policies and processes in place to support telehealth at, of course, a much smaller scale. But today we still run about 15% of all of our visits are telehealth. We see some areas where adoption is much higher. Mental and behavioral health is an example where people sometimes even prefer virtual visits to in-person visits. We see certain post-operative visits and very focused urgent care visits and other things that can be done in a telehealth environment. And that's not only convenient for patients, it also is convenient for the health system where we don't have check-in processes and physical space costs. We've started a program called VTalk, or Virtual Transition of Care, where our hospitalists, led by Dr. Sarah Horman, conduct a post-discharge telehealth visit to ensure that that transition to home has gone effectively. And that's helped to reduce our readmission rates. And so everything's kind of lined up to support a transition to telehealth as more of a routine part of operations. And I think that will continue. But I do think that that was an aberration. And, there's several aberrations over time. The High Tech Act back in 2009, 2010 was another one that spurred a
Yep.
lot of practice adoption of electronic health records. Before that, there was the Institute of Medicine report in 1999 to Err is Human, and the follow-up Crossing the Quality Chasm in 2001, which identified health technology as one key solution for helping prevent medical errors and harm that could be mitigated with this technology. And so we'll see an aberration in the future, but it's impossible to predict what that will be.
100%. Yeah. And I think it just also depends on the organization you're talking about or talking to, because each organization has their own policies, has gone about it certain ways. Obviously, with all the merger and acquisition activity going on in healthcare right now, and EMR conversions going on, is that some hospitals are very much ahead of the game. Some of them are perfectly aligned, and some of them are behind the eight ball, depending on where they are. So I'll be curious to see if hopefully we never have another pandemic, but should one of those aberrations come about again, I'll be curious to see how things transpire with regards to the technological need at that time. So uh, I appreciate your insights there. So what does an IT team need to do, or what does an organization need to do to prioritize new technologies that are being implemented really without interrupting the day-to-day operations? And I'm asking this from your perspective as a physician. You're on the technology side, but you're also a physician, so you're kind of have one leg on each side. So, what's your perspective on that? Like, yes, we need this new technology. I understand from the IT side of what it's going to take, but I also know from the physician side, this is what we need.
Yeah, Larry, one of my early benefits was being mentored not only by the hospital's first CMIO, but also by the hospital's chief quality officer. And where I started my career at Stanford Children's Health, we had a strong perspective that information technology primarily was there to support the high quality of care that we wanted to deliver to our patients. If you think about the 6 elements of care quality as defined by the Institute of Medicine, 25 years ago now, that starts with patient safety, avoiding harm to patients from care that's intended to help them, right? Effectiveness is providing services based off knowledge to those who benefit, avoiding underuse or overuse. Patient-centeredness, or providing care that respects and responds to individual patient preferences, needs, values, et cetera. Timeliness, by reducing waits and harmful delays. Efficiency, which is avoiding a waste of resources, including time, equipment, energy. And then, of course, care equity. And so for those 6 areas, I would say that really any information technology project should be supporting that. If you think about IT and revenue cycle as an example, it's all about efficiency, right? It's automating processes to avoid wasting resources, including people resources, right? At the same time, you think about technologies like computerized prescriber order entry, a lot of that's about safety and entering accurate prescriptions. Think about patient portals and patients being able to schedule their appointments online. That hits a lot of different areas. It's patient-centered, right? It's respecting patient preferences and their ability to schedule when they can want to and need to. But it's also about timeliness, about efficiency, reducing overuse of call centers and things like that. And so to your question about when you adopt new technologies, I really think about, well, what are the outcomes you're trying to achieve? What are the problems that you're trying to solve? It's not about the technologies or the shiny objects, even artificial intelligence, right? AI is not a solution. It's a tool to help solve the problems that we have in healthcare. And we have to be really clear about that, just like a Silicon Valley, startup company or venture capitalist. What problems are we solving and how are we making the processes better by adding automation or technology?
Okay, well, I can't I can't argue that answer, because that makes 100% good sense to me. There's so much to weigh on both sides of that, and I'm sure it's a very fine line to walk and make those decisions. So thank you for that. So my next question is one that has me intrigued. And honestly, when we started planning this podcast, I wanted you on here to talk about this because it piqued my interest. So I'll start by saying that I watch medical dramas on TV. Chicago Med is one of my favorite shows to watch. And a couple of seasons ago, they deployed, which was what they called the hybrid OR, which had cameras all around the room, and it would take all the different scans they inputted and create this 3D model. And it had an AI assistant to help them, you know, through the surgery and make recommendations and so forth. I'm like, wow, that's super cool. I know it's fiction, but I also know that we're not too far off from that. So last year, I saw that UC San Diego Health, along with the Innovation Institute, launched a really cool clinical study where you all were using the Apple Vision Pro in the operating room. And I'm like, man, we are almost to where they're doing this fiction on this TV. So I would love to learn more about that. What was the thought behind it? How did it go? Is it still ongoing? And where do we go from here with that? Because really, that ultimately is like one of those first steps into getting what they're showing and doing fictionally on TV. And it just completely fascinates me.
Yeah, absolutely, Larry. I'm happy to share, and hopefully you can link to the press release that we
Yes.
issued because we were the first health system in the United States to actually use the AVP for patient care in the operating room, and specifically for minimally invasive surgery. So a lot of credit goes to Dr. Ryan Broderick, who's a partner of ours, and had this vision. Now, I want to, mention, acknowledge that augmented reality and virtual reality, whether it's in the perioperative setting, medical education, patient education, or other areas, it's not new. And so the question is, what did the AVP bring that was potentially new? And the answer was, first of all, this was the highest definition AR headset that's ever been released, right? And so you think about some of the other competing headsets, they have more sort of VGA, XGA resolution, 640K or maybe even 1K. But the AVP is actually a 5K headset device. And so that's transformative when you're talking about viewing intraoperative images, from a camera. The second piece of it is just some remarkable technology, and credit to the Apple team for how they made this augmented reality device work in terms of minimizing potential delays and lag that contribute to motion sickness. And so this is actually a device that can be worn, for a longer period of time than most devices where people tend to get that motion sickness from the lag, and it's not a good long-term solution. So for those reasons, we thought it was worth, trialing. And Ryan, really deserves the credit for figuring out how to hook this up. He developed some bespoke software that allowed us to stream from our camera systems as well as our radiology systems and other things. The Jacob Center for Health Innovation, as you said, was at the table helping support him. And I was actually in the room for the very first, surgery, which of course was done under IRB with patient consent. There was a backup option. It was easy to take the headset off. But the entire procedure was completed in the same or less time as it would have been with the traditional approach. And so the question is, what benefit is it bringing? And to understand that, you have to understand how these minimally invasive surgeons are operating. So in the conventional approach, you might have these two trocars in your hand and the patient's in front of you. But where's the screen? Well, you got one screen like, hard left at 9 p.m. And so your entire operating field is in front of you, and yet your head is cranked to the left. Or potentially you've got radiology images to the right at 3 p.m., right? So you're looking over to the right for your radiology images. Occasionally you're looking down at your surgical field. So turns out for that reason, minimally invasive surgeons have some of the highest rates of ergonomic injuries and occupational health kind of hazards. And so our goal with bringing this to bear was to be able to overlay those images. So you have high resolution screen, with your operating field visible in front of you, with potentially, radiology or other imaging in front of you as well. And bottom line is it worked. It worked great. We've done over 60 cases now. We're about to publish our case series. It's gotten attention not only of our, partners that make these cameras and operating equipment, but also of Apple itself. And it's been mentioned even in an Apple earnings call. So we're glad Apple's committed to this long term. And, there's a lot of criticism of the device. I've worn it myself for entertainment and other purposes. Is it too heavy? Yes. Is it too bulky and too much, trouble? You have to set up the eye tracking. You can't easily share it. Yeah, of course, that's all true. It's also the worst it's ever going to be, right? This is first generation technology, and every subsequent iteration is going to get smaller, lighter, and better. So I absolutely believe that, 10, 12 years from now, you're going to have not only surgeons, but consumers, wearing sort of the Ray-Ban glasses with AR projections, on top that are lightweight, that are able to augment your daily life, and perhaps even, replace the device that we're all looking down at all the time. It sounds like an episode of Black Mirror, but I think it's coming quickly. And so it's really important that we're helping to research the way forward from a healthcare standpoint. But that's also why we did this under IRB as a clinical research study so that we could rigorously evaluate the outcomes and share with others that didn't have the same resources. So our lessons learned are that it's great for surgeons. It's doesn't seem to be any slower in terms of use. It may actually be better for patients as well. We're still researching that. And we're publishing this data so that others can learn from our experience. But ultimately, even though these devices today are too expensive for most consumers, at 3,500 bucks a pop, in the space of kind of an operating room environment, that's not a significant expense. And in fact, if you had, a dozen surgeons who are each going to use their own pair of glasses to avoid ergonomic injuries, you're probably going to find a financial ROI off that.
I think it beyond fascinating. Do you see it going beyond your non-invasive at some point in the future? I mean, do you need? Because I mean, I read, I think it was last week or week before, one of the many Apple scoopers out there said that they're working on the next version of this, call it 2.0, that's much lighter. So do you need to have that lighter or newer version of it for it to go into things outside of non-invasive, like an open heart surgery or I don't know, hernia repair or something like that. I'm not a surgeon, obviously. I don't know what's considered 100% non-invasive versus other, but let's just use cardiac, for example.
Yeah.
Does the
So
technology need to improve in order to take it into the non-invasive world?
I think it's a long question, a long answer to a short question. So first of all, minimally invasive surgeries, hernia repairs, et cetera, are often very rapid. These are less than an
Mhm.
hour surgeries. It's not hard to wear the headset during the whole surgery. And we're seeing other surgical specialties adopt it today. In fact, ophthalmology is a great example. At our own Shiley Eye Center, Dr. Tommy Korn has been trying this in different eye surgeries. Um, but there are other types of surgeries, cardiac surgeries tend to be much longer, neurosurgery, et cetera, where, back to our prior conversation, the real question is what problems does it help to solve? And one of the challenges that, let's say, fine tuning, stereotactic neurosurgery face is how do you really overlay this high resolution imaging so that you're operating in exactly the right point? And I absolutely think that these tools can help us with that. So we're beginning to investigate that. But these are also very long surgeries. And so would lighter weight, devices help us with that? Almost undoubtedly. But do we need to wait for that? It's not the entire surgery that's stereotactic that needs to be done with this overlay. So much more to come. There are companies out there today that are doing stereotactic, neurosurgery with other, AR devices, the Microsoft HoloLens and other things. And so will a higher resolution, headset help make that better? Almost certainly. Is it too heavy? As I said, absolutely, but it's the worst it's ever going to get. So I'm excited for what's coming, and I'm excited that the Jacob Center gets to partner with some of our leading surgeons here at UC San Diego to drive this field forward.
It's very exciting. And as someone who, routinely considers myself to be, kind of leading edge when it comes to personal use of technology, I myself did not shell out $3,500 for the headset. But I would definitely check it out, if the cost came down from the personal perspective. But I just think this is fascinating. And I love how, technology like this, it's working its way into healthcare and into surgery. Just because it's, very interesting. It's very innovative. It's advanced, and I feel like at some point in time we're going to catch up to the Jetsons, which came out in the '80s. But of course, we're many moons away from that now. But I just love seeing how all this stuff comes in there. So I appreciate, you kind of diving into that with me. I am looking forward to seeing the results of the study and reading about it. Because again, I just find it interesting. So,
Yeah.
but yeah,
Well, thanks
any
for asking about it, Larry. And I only have one correction to your comments, which is that the Jetsons released in the 1960s, but we're
60s,
definitely
my
still
bad.
catching up.
Definitely
And
still
not only
catching
these
up.
headsets, I think with augmented AI are going to be mind-blowing, but also there's a lot of other technology that was first envisioned in the Jetsons and other science fiction that
Yeah.
we're going to be applying in the operating theater and in the healthcare delivery environment.
I agree. And to go on technology, I still say that Apple missed an opportunity with the Apple Watch not having Michael Knight calling Kit on the watch. So, the technology is coming. So, well, thank you for that. So before we sign off, anything else you want to throw at our viewers here about technology or anything else that we touched on in our conversation today?
Sure, Larry. I think it's hard to close any podcast on health technology without talking about how AI is going to transform some of it. And I'll be the first to say I'm super bullish on generative AI and the opportunity to unlock value in a lot of unstructured data that we previously really haven't been able to access. And I'll give you one example. We had a discrete sort of traditional machine learning approach that was helping us identify sepsis in the emergency department. It works really well to the point that we actually published last year a 20% drop in mortality in our emergency department in sepsis patients. The
Cool.
question is, what happens when you layer generative AI on? And the answer is, it depends on the workflow, stupid, right? In other words, in the emergency department, when we added generative AI, it didn't actually help our algorithm. Why? Because our emergency department doctors wait until their patients are discharged, from the emergency department or admitted to the hospital to write their notes. And so there really wasn't a lot of substrate to add to the predictive value. In contrast, though, we have been trying to do AI-based prediction of sepsis in post-operative patients for some time, and we just couldn't get there with discrete data in the traditional approach. The algorithms were not predictive enough to actually deploy in production. When we added generative AI, it got us over the line. Well, why is that? Well, our surgeons and proceduralists are really good at immediately dictating or typing those notes after a procedure. And similarly, our intensive care units, they've got house staff and others who are immediately writing accept notes when those patients come back. And it turns out all of that text data was really helpful for risk stratifying, who could be at higher risk for post-operative sepsis. And so we're now deploying that in sort of an A/B test to really help us learn if it's going to help save lives the way that our emergency department model has. And so it's a great example of how generative AI can solve some problems and not others. And you really have to understand the workflow and the social context of how all of this comes together in order for the algorithms to make a difference. And so I'll just get on my soapbox for a minute and say it's the outcomes that matter. And I'm sort of tired of hearing about the algorithms, because what we really need to do is we need to measure how these algorithms put into a real world setting with real patients and real doctors and real clinicians is actually going to change outcomes that matter to our patients that we serve. And so I'm excited for next steps and laser focused at the Jacob Center for Health Innovation on how we impact those outcomes.
Well, that's exciting. And yeah, the whole AI thing to me, I mean, we were at, between Vive and HIMSS and God knows how many blog articles and everything. AI is such a buzzword right now, and everybody is getting into it. You have so many different models out there. I'm excited to see where it can go. I'm also scared as to where it's going to go and how it's going to get there. Um, I mean, Skynet became self-aware, right? We have to worry about that. You've seen how some of these models respond to things. They have their own personality and so forth. But the fact that you are already seeing meaningful outcomes with the incorporation of it is fantastic. And that's obviously a lot of credit to your docs and so forth as they go through and are doing all this stuff. But yeah, I agree with you 100% on that one. I'm really looking forward to seeing where it goes.
Yeah. I was at a recent summit around AI. Of course, there's one of these every week. I like the way that they were structuring their thinking about AI in healthcare. They used three different areas. The first was operational uses. How do you make the system more efficient and take out unnecessary cost? The second is clinician use. How to use it for better diagnosis or better outcomes or higher quality care. And the third was patient-facing use. We know a lot of our patients are using AI. We've heard lots of anecdotes and stories about how AI is helping patients directly, but we really have yet to measure how we can do that, at a
Yeah.
healthcare delivery standpoint. And so if you think about those three categories, operational use is clearly going to be the first to adopt it and is today because it's lower risk. Where I think the caution comes in is let's make sure that we're not using AI to solve the wrong problems. In other words, let's not use AI as a band-aid. When we
Mhm.
implement electronic health records in many places, we paved the cow paths, right? We just hardened some really bad processes around billing and coding and other things by adding the electronic health record to existing processes. And I hope we don't try to do the same thing in AI. This is the classic example, the battle of AIs between the insurance company using it to review claims and the hospital using it to help submit claims. Let's fix the underlying problems. Like, let's do the hard work rather than just trying to add AI on top of these things. There's lots of places where AI can help transform call centers or transform business processes that are too inefficient today. But we also need to be mindful of just improving those business processes. In the second space, clinician-facing AI, that's what we've been talking about, Larry. We need to really measure those outcomes that matter. And the sepsis use case I just gave is one of several dozen that we're testing today. I'm excited for
Yeah.
that, but I think we're going to see that adopted a little bit slower because it needs to hit that bar just like a new drug. Let's prove that this helps before we start paying for it, right? And then the third
Yeah.
piece on the patient-facing AI, I think there's huge opportunities here to better empower our patients in a really systemized fashion. Not just, one patient happens to know how to use, a chat GPT and starts copying and pasting, clinician notes that are available because of the Cures Act, but rather let's make this systematically available to our patients to help them better care for themselves using remote monitoring data, inter-visit care, automated care loops, et cetera. And there's all sorts of companies coming up in this space. But like the clinician-facing AI, we've got to measure it and show that it works before we adopt it, pay for it, and deploy it at scale.
Yeah. I couldn't agree more. I could not agree more. So thank you for the extra added insight there. I'm glad we're able to include AI in this conversation. So that concludes our discussion today on Visionary Voices. I want to thank my guest, Dr. Chris Longhurst, for joining me today, for sharing his insights. And to our audience, thank you for tuning in again to Visionary Voices, powered by Optimum Healthcare IT. And remember, the future of healthcare IT starts with your vision. We'll catch you next time.
Thanks, Larry, and thanks to Optimum Health IT for supporting the podcast.